Hello, everyone. Thank you for joining. We're just going to let other people join, so we'll give it a minute or two. Thank you for your patience. Good afternoon, everyone. Thank you so much for joining us for the Upgrade Oncology Pathology series. Today, we're very excited to have a little bit of a pathology celebrity, Dr. Andrew Bellizzi, who's known as the IHC guy. I will let him introduce himself, but he is massively overqualified to give this talk, and this is one of my favorite talks on immunohistochemistry and tumor lineage that he gives. And I will let him introduce himself and go from there, and we will do questions at the end. Andrew, take it away.
Sure. Hi, everybody. I don't know about massively overqualified or pathology celebrity. I'm Andrew Bellizzi. I'm a GI pathologist at the University of Iowa Hospitals and Clinics. And I'm the IHC laboratory director at the University of Iowa. And over the last 15 years or so, I've done quite a lot of work in the immunohistochemistry space. I'm lucky to know Dan from our time together at the Brigham. I was at Brigham and Women's Hospital with Dan from 2009 to 2011. We've got a talk entitled Immunohistochemistry to Assign Tumor Lineage and Site of Origin. So this is the talk that'll help you figure out whether the tumors carcinoma, sarcoma, lymphoma, melanoma, mesothelioma, germ cell tumor, or paraganglioma, pheochromocytoma. And then once you get to carcinoma, whether it's an adenocarcinoma, squamous cell carcinoma, neuroendocrine tumor carcinoma, urothelial carcinoma. And then, especially if it's an adenocarcinoma or neuroendocrine tumor, where that tumor might be arising. And I think sort of inherent in that is making the right tumor diagnosis is incredibly important around prognosis and therapy. And I'm delighted to have long, loose time. We've got up to 2 hours, and sometimes I try to give this talk in an hour, and it's very challenging. And one time I tried to give this talk in 30 minutes, and that was incredibly challenging. Disclosures and shameless plugs. I have no financial relationships to disclose, which is not having financial relationships is a personal value. I do have a bunch of shameless plugs. As Dr. Milner mentioned, I'm known as IHC guy, and I'm very active on social media. I often have my head buried in my phone tweeting as I'm walking in from the parking lot. So if you're on Twitter, you can follow me at IHC_guy. And then here are a bunch of things that I'm associated with that I'd also appreciate a follow for. So at ISOMWeb, that's the International Society for Immunohistochemistry and Professional It's a little early. I know it's late afternoon or evening for me, but it's early for me and I'm slightly under caffeinated. ISOM is the International Society for Immunohistochemistry and Molecular Morphology. It's the professional organization devoted to immunohistochemistry. At AIM Journal is Applied Immunohistochemistry and Molecular Morphology, and this is the Immunohistochemistry Journal. At PathPod is a pathology podcast, and I record episodes devoted to immunohistochemistry with co-hosts Sanam Lagavi and Michael Arnold. And then at UI Pathology is my home institution. And without their support and their histology lab and all these cases, I wouldn't have anything to present to you. And then a lot of what I'm presenting in this lecture is covered in a lengthy review article that I published in Advances in Anatomic Pathology back in 2020. And I'll say, the most important thing about giving these talks is establishing personal relationships. It's unfortunate that this is by Zoom, but I encourage everybody to reach out to me. And if anybody wants these slides or any of these references, please let me know by email or through my Twitter handle, and I'm happy to dialogue with you. An extra plug for ISOM, the International Society for Immunohistochemistry and Molecular Morphology. We put on a monthly immunohistochemistry webinar, and actually we did one yesterday. My friend Dennis O'Malley discussed classical Hodgkin lymphoma, and I encourage everybody to follow ISOM and to participate in our monthly webinars. We've got one coming up on June 14th, and then we'll take a couple months off for the summer, but we'll be back in the fall with more programming. All of these 20, we're up to 21 now, webinars are recorded and are available on the ISOM website. So the value proposition for this hour-and-a-half plus of lecture is you'll never have to be stumped again because you've made a friend. Here again, here's my email address and my Twitter handle, and you'll have an immunohistochemical panel for virtually everything. Incredibly important take-home point. This is probably the most important point for the lecture. I say, don't be penny wise and pound foolish. Here's a tissue block with 3 liver cores, and this is how we used to deal with medical and tumor liver biopsies in my lab. And we had an incident a few years ago, 4 or 5 years ago now, where the overnight tech, it was a medical liver biopsy, faced through the block and wasn't able to capture any of the tissue on the glass slides. And the way that we responded to that is, well, we said, well, never again. And now whenever we get at least 1 liver biopsy, or even if we get a longer liver biopsy, we'll divide it. We'll incise it and divide it into 2 cassettes, but we always will divide medical liver biopsy, tumor liver biopsy, endobronchial biopsy. If there are multiple biopsies, divide them into at least 2 blocks. And every biopsy is a potential molecular specimen if you have access to molecular pathology. Every biopsy is a potential oncology specimen, useful for immunohistochemistry. And so in our practice, we reserve 1 block for molecular testing and do all our immunohistochemical workup in the other tissue block. And then another really important take-home point around immunohistochemistry is to use a stepwise panel-based approach rather than a shotgun approach. And you should have a morphologically and epidemiologically informed differential diagnosis. You should have an immunopanel that's directed at that differential diagnosis. And based on the potential results of that initial immunopanel, there should be a subsequent immunopanel that you planned, and in some cases, a tertiary immunopanel. And whenever I'm going to order immunohistochemical stains, I always cut extra unstained upfront, anticipating at least the second panel. We want to cut into the tissue block as few times as possible. So prerequisites, more important than the immunohistochemical approach, is this morphology and epidemiology based approach. And I'll say incredibly important considerations when I sit down with the trainees at the microscope and they have a tumor case, a tumor biopsy, the first questions I ask are, how old is the patient? Are they a man or a woman? And where's the biopsy derived? And this is going to drive the differential diagnosis. Another important point, always consider primary versus metastasis. And I'll say I have made a consistent observation across my career that when folks encounter a tumor that they don't immediately recognize, and most of the time we immediately recognize the lesion, but when we're confused, for some reason our brain jumps to metastasis. And a common error in tumor diagnosis is failure to consider the range of primary types that might arise at that anatomic location. So, for example, I just showed you guys liver core biopsies. One of the most common quote unquote carcinomas of unknown primary to present in the liver is primary intrahepatic cholangiocarcinoma. And people see adenocarcinoma in the liver. I guess they think liver, hepatocellular carcinoma. So they see adenocarcinoma, and their mind and their immunopanel immediately goes to the range of adenocarcinomas that might present in the liver, and failure to consider the primary tumor type that arises at that anatomic location. Another famous example that sometimes I show in lectures like this is epithelioid sarcoma, which would arise in somatic soft tissue. You've got a subcutaneous lesion, it's epithelioid malignant neoplasm. And unless you've seen a bunch of epithelioid sarcomas, your mind immediately goes to what kind of adenocarcinoma is this? And then you're subject to confirmation bias. You suspect adenocarcinoma, you do a keratin, it's positive, and then you start chasing a site of origin, which will be fruitless around this, what is actually an epithelioid sarcoma. Third, incredibly important orienting point, I say that around immunohistochemistry for tumor diagnosis, there are screening markers and differentiation markers, and we only have a handful of screening markers. Broad spectrum epithelial markers like broad spectrum keratin, and there are several, and we'll discuss different broad spectrum keratins. CD45, also known as leukocyte common antigen, SOX10 or S100, SAL4. This is it for screening markers. Everything else is a differentiation marker. And if you're uncertain as to the broad tumor lineage, carcinoma, sarcoma, lymphoma, melanoma, etc., don't start ordering differentiation markers until you've locked down the broad tumor class. And so a common panel for me is keratin 8E1, 8E3, CD45, and SOX10. If I have on light microscopy on H&E, an undifferentiated malignant neoplasm. And then depending on the anatomic location, I might add SAL4 to this panel. So outline for the talk, which is pretty ambitious. We're gonna hit all of these topics: broad tumor classes and associated screening markers that I've sort of introed: carcinoma, sarcoma, lymphoma, melanoma. We'll talk again about broad spectrum epithelial markers, broad spectrum keratins, compare and contrast S100 and SOX10, which are screening markers for melanoma mainly, but have other diagnostic applications. Discuss what I refer to as non-canonical expression of broad tumor class markers. Briefly, we'll do the IHC workup of a small round blue cell tumor, the differential diagnosis for what I refer to as a quote unquote triple negative malignant neoplasm, and that's a tumor that's negative for a broad spectrum epithelial marker, CD45 and SOX10 or S100. We'll talk about the clinical aspects of the carcinoma of unknown primary, and why you should be motivated to make as specific a tumor diagnosis as possible. We'll lean in on this epidemiology-based approach to tumor diagnosis. Common things are common. It's more likely to be an unusual morphologic presentation of a common tumor than even a fairly typical presentation of an uncommon tumor. We'll do IHC for diagnosis of carcinoma type, and this is adenocarcinoma versus what I refer to as large polygonal cell adenocarcinoma versus squamotransitional carcinoma versus neuroendocrine tumor and carcinoma. And then we'll talk about coordinate expression of Keratin 7 and 20. IHC workup of what I refer to as the garden variety adenocarcinoma presenting in the liver. These are adenocarcinomas that are readily recognizable as adenocarcinoma. The gross and immunohistochemical workup of a primary surface ovarian tumor versus a metastasis with mucinous features. Then I've got some additional site-specific IHC algorithms. Remember, I said age, gender, anatomic location. The panel will be determined based on these, especially anatomic location. Differential diagnosis of squamous cell carcinoma versus urothelial carcinoma with immunohistochemistry. Immunohistochemistry for neuroendocrine tumor site of origin. Immunohistochemistry for neuroendocrine carcinoma site of origin. Immunohistochemistry for neuroendocrine tumor grade 3, well-differentiated neuroendocrine tumor grade 3 versus neuroendocrine carcinoma, and an immunohistochemical approach to undifferentiated carcinoma. So first, broad tumor classes with associated screening markers. High-grade malignant neoplasm, uncertain as to tumor lineage. These are the considerations, the associated screening markers, when to consider them in terms of morphology, anatomic location, and results of an initial screening panel, and then additional immunohistochemical markers that might be useful to confirm the diagnosis. And I say for in the skin and viscera outside of the brain, we're not doing, I do everything but glioma. Outside of the brain, I say big 4 plus 3 more, and I've already rattled them off a few times, and I find it useful to rattle them off. I rattle them off at the microscope as a mantra so that I don't forget. So it's carcinoma, sarcoma, lymphoma, melanoma. Those are the big 4. And then plus 3 more: germ cell tumor, mesothelioma, and paraganglioma pheochromocytoma. And in the prior slides, I said there are screening and differentiation markers. So our screening marker for carcinoma is a broad spectrum keratin. There are alternatives. There are additional broad spectrum epithelial markers, notably immunostains to EpCAM, or epithelial cell adhesion molecule. And these are generally referred to by their clone names. MOC31 and BER-EP4 recognize EpCAM, EMA, epithelial membrane antigen, and Claudin-4. For hematolymphoid, we typically screen with CD45. CD43 is a nice backup. TDT, if you're considering lymphoblastic lymphoma. We'll come back to additional immunos to consider ordering in a possible hematolymphoid neoplasm, with this panel being directed at tumors that tend to be CD45 weak to negative. Melanoma, we screen with SOX10 or S100. I generally prefer SOX10 to S100. It's marginally more sensitive. There is one instance in which I prefer S100, or I might order them together, and that's in a decalcified specimen. Transcription factors are susceptible to weaker to absent staining in the setting of strong decalcification, but generally I favor SOX10. There isn't a screening marker for sarcoma. They have to be recognized based on morphology, but really what's critically important is anatomic location. So always consider sarcoma in the mediastinum, retroperitoneum, or in somatic soft tissue, or I should add in the peritestis. And of course, tumors with spindle cell cytomorphology, though there are sarcomas with epithelioid cytomorphology. Common sarcomas that are not readily recognized as sarcoma. And, perhaps it's easiest if you're in somatic soft tissue and you have a spindle cell tumor that's malignant to consider the diagnosis of sarcoma. But difficult to classify malignant neoplasms in the mediastinum, retroperitoneum, or peritestis. Dedifferentiated liposarcoma is a principal diagnostic consideration, and immuno for that is MDM2 and CDK4. We also use FISH for MDM2, and more recently, chromogenic in situ hybridization for MDM2 amplification. Epithelioid neoplasms defying typing, and I alluded to this in the always consider primary versus metastasis in that intro slide. So epithelioid sarcoma is often originally considered to be thought to be a carcinoma. And so if I'm struggling, INI1 to support a diagnosis with epithelioid sarcoma. Angiosarcoma, particularly angiosarcomas with epithelioid cytomorphology, are often thought to be carcinomas, and sometimes we never make the diagnosis. So if you think something's carcinoma, but you're uncertain as to adenocarcinoma versus squamotransitional carcinoma versus neuroendocrine tumor carcinoma, consider the possibility of angiosarcoma, which are frequently keratin positive. And we do ERG for angiosarcoma. There are other markers as well, CD31, CD34. This is as a last-ditch effort in undifferentiated malignant neoplasm carcinoma versus sarcoma. CD34 positivity is not uncommon in undifferentiated sarcoma, and it's rarely expressed by carcinoma. There are a few exceptions, notably nut midline carcinoma is not uncommonly CD34 positive. Germ cell tumors. So that was the big four. Plus 3 more germ cell tumor we screen with SAL4. Always consider germ cell tumors in the midline, in the mediastinum, in the retroperitoneum, where it might be lymph node metastasis from a gonadal neoplasm, or in the gonads. And we've got immuno to subtype germ cell tumors. Seminomas are OCT4 KIT and D240 positive. Embryonal carcinomas are OCT4, CD30, and SOX2 positive. Yolk sac tumors are AFP and glypican-3 positive. Trophoblastic tumors are beta HCG, GATA3, inhibin A, and PDL1 positive. Mesothelioma. This is another example of failure to consider the primary tumor. So always consider mesothelioma for an epithelioid or spindle cell. Though generally epithelioid, malignant neoplasm in the pleura or the peritoneum. And I see lots of peritoneal mesotheliomas that are big immunohistochemical workup. What kind of carcinoma is this? What's the site of origin? I'm not sure. And I say, well, what's the biopsy? Peritoneum? Did you consider mesothelioma? Oh, no, I did not. And here are markers to support a diagnosis of mesothelioma. I usually start with calretinin and WT1. Other markers, D240, CK5-6, BAP1 loss, and I should add MTAP is a new marker for mesothelioma, MTAP loss. Paraganglioma pheochromocytoma are general neuroendocrine marker positive. They are keratin negative, and distinguishing a neuroendocrine tumor from paraganglioma pheochromocytoma can be, well, should always be performed. So a broad spectrum keratin to support a diagnosis of neuroendocrine tumor. And then we've got positive markers for paraganglioma pheochromocytoma, namely GATA3 and FOX2B. We could also look for SDHB loss, which is common in especially thoracoabdominal paragangliomas. So this is a really important slide. If you were gonna hang on to one slide from this lecture, this is the one slide for tumor lineage. And actually, on Twitter, I refer to these as wall hangers because I hang them on my wall and I refer to them during my sign out when I'm stuck. I'll point out some of the other wall hangers as we go along. So here's an example of the utility of broad tumor classes with associated screening markers. This was a 44-year-old man with a retroperitoneal mass, and here was an initial immunopanel that was performed, and this was biopsied, depleted, with no diagnosis, re-biopsied, and some of my colleagues were considering sending this case out, and my fellow made the diagnosis. So a broad spectrum epithelial marker, keratin 8E1-8E3, negative, also CK5-6, which is a screening marker for squamous cancer, S100 and SOX10, HMB45, Melanoma, SMA, and Desmond. And so carcinoma was considered, sarcoma was considered, melanoma was considered, but the key here is retroperitoneal mass. Here's a SAL4, and here's a kit, and this was seminoma, metastatic to retroperitoneal lymph nodes, and this diagnosis was almost missed because of failure to consider the possibility of germ cell tumor, and germ cell tumor should always be considered in the mediastinum, retroperitoneum, or gonad. So this wall hanger, which my fellow had, imbibed over the course of his training, saved the day. He ordered a SAL4 and then confirmed the diagnosis of seminoma with a kit immunostain. So very common question is, which screening keratin should I use? And there are a bunch of broad spectrum keratins. I use keratin 8E1-8E3. And 8E1-8E3 based assays are in the widest clinical use. Here are a bunch of other choices. One potential weakness of keratin 8E1-8E3 is it doesn't recognize cytokeratin 7 and 18, which are pretty widely expressed low molecular weight keratins. So there are multiple commercially available cocktails that add usually CK7, which is a monoclonal antibody that specifically recognizes keratin 18. But I find in my practice that the lack of 8E1-8E3's recognition of 7 and 18 doesn't interfere with its utility as a broad spectrum epithelial marker in screening for carcinoma. Some of the other ones to specifically mention, CAM 5.2 only recognizes low molecular weight keratins. So CAM 5.2 is a powerful tool in your IHC armamentarium, but it can't be deployed alone as a broad spectrum epithelial marker because it doesn't recognize high molecular weight keratins and won't secure your diagnosis of squamous or urothelial carcinoma, for example. 34 beta E12 only recognizes high molecular weight keratins. And I'm sort of alluding to this around, this low molecular weight keratin you won't be able to make this diagnosis. Stratified epithelia express high molecular weight keratins, and those are keratins 1 through 6 and 9 through 17. And 34 beta E12 only recognizes these high molecular weight keratins. And stratified epithelia, squamous epithelium and squamous cell carcinoma, urothelial carcinoma. And then simple epithelia express the low molecular weight keratins 7, 8, 18, 19, and 20. And CAM 5.2 only recognizes these low molecular weight keratins. So simple epithelia and cognate neoplasms, mainly adenocarcinoma, express these low molecular weight keratins. Everything else here, AE1, AE3, MOX6, MNF116, KALA1, simultaneously recognized low and high molecular weight keratins. And I use AE1, AE3, and people fixate over, which specific keratin subtypes a clone recognizes or doesn't recognize, but I'll emphatically make the point that it doesn't matter how many keratins your pan-keratin reacts with if it isn't well optimized. And I see poorly optimized broad spectrum keratins in my practice in the consult material every day. And so here is a huge opportunity to improve the performance of your lab. A well-optimized broad spectrum keratin is one of the most powerful immunohistochemical tools that you can have. And these are images from the Canadian External Quality Assessment or Proficiency Testing Program for immunohistochemistry, and specifically in their survey for low and broad spectrum keratin. At the top here, we have a well-optimized AE1, AE3. And at the bottom, we have a poorly optimized AE1, AE3. Different epithelia stain, intrinsically more strongly for this marker because they make more keratins. And so in liver, we've got cholangiocytes and hepatocytes. And in kidney, we have the glomerulus, we have the parietal epithelium, we have the proximal nephron, and the distal nephron. And in the liver, cholangiocytes make more keratins than hepatocytes. And in the kidney, the distal nephron makes more keratins than the proximal nephron. And in well-optimized broad spectrum epithelial markers, you'll have a gradation of expression, but hepatocytes and cholangiocytes will be reactive. And the proximal and kidney, the proximal and distal nephron will be reactive. And if you look at a poorly optimized keratin AE1, AE3, you'll see here that hepatocytes are not reactive and that the proximal nephron's not reactive. And if your broad spectrum epithelial marker doesn't react with hepatocytes, guess what? It's not going to react with hepatocellular carcinoma. And if your broad spectrum epithelial marker doesn't react with the proximal nephron, it's not going to react with renal cell carcinomas that recapitulate the proximal nephron, namely clear cell renal cell carcinoma and papillary renal cell carcinoma. And lots of poorly differentiated carcinomas make less keratin rather than more, and it's incredibly important for your broad spectrum keratin to be able to recognize smaller amounts of keratin. And actually, these are wonderful tissue types, liver and kidney, in which to optimize your broad spectrum keratin. S100 versus SOX10. Their main function in the tumor of uncertain lineage is to recognize or to screen for melanoma. And these are more broadly are markers of melanocytic differentiation, nerve sheath differentiation, and neoplasms with myoepithelial differentiation. And Melanomas, nerve sheath tumors, and neoplasms with myoepithelial differentiation often co-express S100 and SOX10. I mentioned at the outset that I generally favor SOX10 over S100 because it's incrementally more sensitive. So there are some SOX10 positive, S100 negative tumors because of that increased sensitivity. There is one tumor type that's SOX10 positive and S100 negative, and that's a actinic cell carcinoma because SOX10 not only reacts with myoepithelial cells in the salivary glands, it also reacts with serous acinar cells in salivary glands. There are a bunch of tumors that are S100 positive and SOX10 negative, but they tend to be rare tumors. But this S100 positive SOX10 negative immunophenotype is sometimes the clue to the diagnosis. I'll mention a case that I saw a few weeks ago that's exemplar. S100 and SOX10. S100 reacts with fat and cartilage and associated tumors. Chordoma is a good example of an S100 positive SOX10 negative tumor, and this immunophenotype in combination with keratin positivity you can use to support the diagnosis of chordoma. Brachyury would be the next gen IHC transcription factor that you'd use to support the diagnosis of chordoma. There are a bunch of translocation associated mesenchymal tumors that are S100 positive, SOX10 negative. I've listed a few here. Occasionally, a small round blue cell tumor will be S100 positive, and so this is Ewing, rhabdomyosarcoma, synovial sarcoma. These are typically SOX10 negative. Occasionally, carcinomas without myoepithelial differentiation are S100 positive, and these can be S100 positive and SOX10 negative. And then here, I had mentioned that I had a case recently, and it was an interdigitating dendritic cell tumor, which is a very challenging tumor diagnosis to make. We'll sort of come back to these histiocytic and dendritic cell tumors when we talk about tumors not to miss before busting, striking out, failing to secure a diagnosis in a quote unquote triple negative malignant neoplasm. And I recently saw a tumor, an interdigitating dendritic cell tumor, where the diagnosis was suggested by this S100 positive SOX10 negative immunophenotype. So the point being, S100 is positive in a bunch of histiocytic and dendritic cell tumors, and SOX10 is negative, is never positive. And then we've got S100 negative, SOX10 negative, and that's most things. So most carcinomas, sarcomas, lymphomas, mesotheliomas, germ cell tumors, and parapheo, with the exception that both S100 and SOX10 are expressed by sustentacular cells. This is a very common consultation, and I'm using this case to talk a little bit more about S100 and SOX10. So this is a 55-year-old woman with a core biopsy of an inguinal lymph node, which shows pink spindly neoplasm, and it came with the question, rule out nerve sheath tumor. And this was overtly malignant. It's in a lymph node. It was mitotically active, and the tumor simultaneously strongly expressed S100 and SOX10. And this immunophenotype excludes malignant peripheral nerve sheath tumor. Spindle cell malignant peripheral nerve sheath tumors are almost always S100 and SOX10 negative, and if they're positive, they're typically only weakly positive. So this is a spindle cell melanoma. Here's a typical histomorphology for malignant peripheral nerve sheath tumor, and the clinical history was corroborative. The patient had a history of neurofibromatosis. Here's a very characteristic S100 in a malignant peripheral nerve sheath tumor. It's negative. And the best immunohistochemical marker to support a diagnosis of malignant peripheral nerve sheath tumor is H3K27 trimethyl. So this is a histone methylation mark that is absent, is lost in the majority of malignant peripheral nerve sheath tumors. So we're visualizing loss of expression in the tumor cells with intact expression in internal control, mainly lymphocytes. I want to talk a little bit about melanoma markers in these three main variants of melanoma, namely conventional or epithelioid, spindle cell, and desmoplastic. Folks, and I showed you an example in that seminoma. One of my colleagues did S100, SOX10, Melan-A, and HMB45. And there is, in my opinion, there's no added benefit to adding Melan-A and HMB45 in a melanoma. You're not going to see a Melan-A positive HMB or HMB45 positive melanoma that's S100 or SOX10 negative. So that's, again, we screen with SOX10 or S100, or possibly both. And the rate of S100 and SOX10 positivity in these variants, it approaches 100%. Most conventional or epithelioid I almost said mesothelioma melanomas express these, what I refer to as quote unquote melanoma differentiation markers. So they're usually Melan-A positive and HMB45 positive. I don't use MID-F in my practice. It's too non-specific. I don't use tyrosinase. Here's just sort of an interesting observation that MUM1, which is a marker typically used to support plasmacytic differentiation, is usually positive in conventional melanoma. So one common consult is this is melanoma. The patient has a history of melanoma. It's metastatic melanoma. It's S100 and SOX10 positive, but Melan-A and HMB45 are negative. Am I wrong? Is this something else? And no, it's fine. 15% of melanomas are negative for these markers. So it's okay to have even a conventional melanoma that's Melan-A and HMB45 negative. But more commonly, it's a spindle cell melanoma. And the question is, what is the diagnosis? Is it malignant peripheral nerve sheath tumor, or am I missing something in the spindle cell neoplasm that's S100 and SOX10 positive and not positive for anything else? And at least half of spindle cell melanomas are negative for melanoma differentiation markers. And in desmoplastic melanoma, the vast majority of desmoplastic melanomas are negative for these melanoma differentiation markers. On to non-canonical expression of broad tumor class screening markers. So these are instances in which broad spectrum epithelial markers like keratins and EMA are positive in sarcoma, lymphoma, melanoma, and germ cell tumor. Instances in which melanoma markers like S100 and SOX10 are positive in mainly carcinomas, and then instances in which hematolymphoid markers are positive in carcinomas and melanomas. And I'll just mention a few. I'll highlight a few. So broad spectrum epithelial markers, and I've made this point a few times already mainly around epithelioid sarcoma. I also mentioned it in terms of angiosarcoma, that sarcomas can be broad spectrum epithelial marker positive, and they can be diffuse and strong. And if the cytomorphology of the sarcoma is epithelioid, it's more likely to be positive for broad spectrum epithelial markers. So sarcomas with epithelioid cytomorphology, again, epithelioid sarcoma, epithelioid angiosarcoma, they're often going to be diffuse strong. for a broad spectrum keratin. But also leiomyosarcoma, not uncommonly, small round blue cell tumors like Ewing sarcoma can have some keratin positivity. This we'll come back to in just a minute. EMA positivity is consistently seen in a set of hematolymphoid neoplasms, plasma cell neoplasm, anaplastic large cell lymphoma, some diffuse large B-cell lymphoma variants, also nodular lymphocyte predominant Hodgkin lymphoma, though I don't think that one would mistake that for carcinoma, and follicular dendritic cell sarcomas can be EMA positive. And the pitfall here is the lymphomas that tend to be EMA positive tend to be CD45 weak to negative. Melanomas occasionally express broad spectrum epithelial markers, though the extent of expression is always less than the extent of staining and intensity of staining for S100 and SOX10. Yolk sac tumors are always strongly positive for broad spectrum epithelial markers. Choriocarcinomas are always strongly positive for broad spectrum epithelial markers. Embryonal carcinomas are plus minus. Seminomas are almost always dead negative or can have like very focal weak staining. Melanoma markers, I mentioned S100 can be positive in carcinomas, usually reflecting myoepithelial differentiation. SOX10 is positive in tumors with myoepithelial differentiation. And this is an example of something that I refer to as pitfall opportunity. So, pitfall, if you're unaware, you can take advantage of it, use it. It's an opportunity if you're aware. So triple negative breast cancer is an important consideration in the CUP carcinoma of unknown primary setting. Triple negative breast cancers show myoepithelial differentiation, and 60% of triple negative breast cancers are diffusely strongly positive for SOX10. I say CD45 never lies. So CD45 shows great lineage fidelity, but CD138, which is often utilized as a marker of plasmacytic differentiation, is frequently positive in carcinomas. Almost half of carcinomas are positive for CD138. So a diagnostic error that I've made is calling an undifferentiated carcinoma a plasma cell neoplasm based on CD138 expression. So here's a case to illustrate one of these points, this non-canonical expression. This is a 77-year-old man that had a lytic lesion in the T-spine, and he has a remote history of prostate cancer. And so 77-year-old man, his remote history of prostate cancer. One thing I'll say is never ignore a personal history of malignancy. If a patient has a personal history of malignancy, the diagnosis is almost always recurrent or metastatic, whatever that personal history of malignancy was. So we're anchored on a history of prostate cancer here, and this cytomorphology is okay. Prostate cancers are monomorphous, monotonous. I see some somewhat prominent nucleoli here. I will say that the morphologic assessment is slightly challenged by a little bit of decal. And here was the initial immunohistochemical workup that was, reasonable and parsimonious and directed at this favored differential diagnosis of prostate cancer. And it was keratin 81, 83, PSA, PSAP, and it was negative. So second panel, expanded additional markers to try to support that diagnosis of prostate cancer, and expanded the differential to consider the possibilities of lymphoma. So we've got androgen receptor, which is a prostate cancer marker, RB, which is often lost in castration-resistant prostate cancer. ERG, which is positive in half of prostate cancers that harbor this TMPRSS2 ERG fusion. And then additional broad spectrum epithelial markers, MOC31, EMA, and then CD45. And the only marker at this point that's positive is EMA. A third immunohistochemical panel added Taxate, Melon-A, chromogranin, synaptophysin, and Sal4. So this is directed at carcinomas that tend to be broad spectrum epithelial marker weak, and that can be EMA only, and that's RCC, adrenocortical carcinoma, and neuroendocrine neoplasm, also considering the possibility of a germ cell tumor. All negative. And then at this point, the case was shown to me, and I saw the histomorphology and what I refer to as quote unquote EMA only. And that's a tumor where you've done a bunch of immunostains and the only thing that's positive is EMA. And I added CD43, CD79A, CD138, kappa and lambda light chains, ALK, and SOX10. And here's the CD138. And critically in this case, this tumor was kappa light chain restricted, and this is a plasma cell neoplasm. So I've alluded to this EMA only, and these tumors that tend to be EMA only, these hematolymphoid tumors that tend to be EMA only. Plasma cell neoplasm, plasmablastic lymphoma, anaplastic large cell lymphoma, ALK positive diffuse large B cell lymphoma, and follicular dendritic cell sarcoma overlaps with tumors that tend to be CD45, which is our mainline hematolymphoid screening marker, CD45 weak to negative. And so whenever EMA only, my mind goes to this differential and this wall hanger, actually. Flexing to the immunohistochemical workup for a small round blue cell tumor. Always age, gender, anatomic location, but here's the scaffold for an immunohistochemical workup. So CD99, screening marker for Ewing sarcoma. NKX 2.2 is a more recently validated, publicized marker of Ewing sarcoma. Desmin and myogenin for rhabdomyosarcoma. CD45 for lymphoma, but if it's really a small round blue cell tumor, the main diagnostic consideration is lymphoblastic lymphoma, which tend to be CD45 weak to negative, so screen with TDT. INSM1, pan-keratin, SOX10. So we've still got our, keratin, LCA, SOX10 or S100 backbone here. But pan-keratin for carcinoma, SOX10 for melanoma, INSM1 for small cell neuroendocrine carcinoma. And then a couple other points. Desmoplastic small round cell tumor, especially in the abdomen of a younger man. This is a polyphenotypic tumor that should be positive for Desmin, often dot-like, and should show some broad spectrum epithelial marker positivity, and might show some general neuroendocrine marker positivity. A few common pitfalls. CD99 has to be diffuse and strong to support the diagnosis of Ewing sarcoma. Lymphoblastic lymphoma especially can also be diffuse and strong in the membrane for CD99. This NKX 2.2 that we use for Ewing sarcoma is also positive in olfactory neuroblastoma and often positive in mesenchymal chondrosarcoma. I often use Desmin to support a diagnosis of malignant peripheral nerve sheath tumor. I said the mainline diagnostic for that is H3K27 trimethyl, but a significant minority of malignant peripheral nerve sheath tumors show a component of rhabdomyoblastic differentiation and express desmin or myogenin. Pitfall for the myogenin is its re-expression in atrophic skeletal muscle fibers. A neat trick with INSM1 in the sarcoma space is it's also expressed by extraskeletal myxoid chondrosarcoma and is really the only consistently positive specific immunohistochemical marker for that sarcoma diagnosis. I really like this slide. This is a wall hanger for a small round blue cell tumor, and then this is my wall hanger for it's a small round blue cell tumor. I did this immunohistochemical workup and didn't arrive at a specific diagnosis. I found this paper published about 5 years ago that looked at a cohort of patients where the original diagnosis that was favored was Ewing sarcoma, but in which the EWSR1 FISH was negative. And here are all the ultimate alternative diagnoses listed in descending order. And then I've added diagnostic markers that I use to support these diagnoses. So CHIC or SIC or CIC rearranged and B-core associated sarcomas, sometimes referred to as quote unquote Ewing-like. I use WT1 immunohistochemistry to screen for these and B-core to screen for these. Although before I had optimized and validated B-core, I used SATB2 actually to screen for these. Neuroblastoma, which would be especially common in the retroperitoneum. Markers for neuroblastoma include FOX2B especially. Malignant rhabdoid tumor, SMARCB1, and we'll talk more about SWE/SNF immunohistochemistry in a bit. Clear cell sarcoma is SOX10 positive. Some of these we've talked about: MPNST H3K27 trimethyl, desmoplastic small round cell tumor, these polyphenotypic tumors that are keratin, desmin, and broad spectrum or general neuroendocrine marker positive, that's NSE. Poorly differentiated synovial sarcoma, we've recently flexed from using TLE1 to support the diagnosis of synovial sarcoma to SS18 SSX fusion specific immunohistochemistry or SSXC terminus immunohistochemistry, GIST, KIT and DOG1, and then SMARCA4 deficient sarcoma, SMARCA4 BRG1. But again, we'll talk, as with SMARCB1, INI1, we'll talk more about these SWE/SNF subunits and associated immunohistochemistry actually at the end of the lecture. So 15 diagnoses to consider before saying high-grade malignant neoplasm, lineage uncertain. On a triple negative, again, that's broad spectrum epithelial marker and maybe lots of broad spectrum epithelial markers, all that you have. LCA, CD45 and or CD43, S100 SOX10, malignant neoplasm. Your screen before you did your screening markers and you can't figure out what it is. And this list is at 15. It used to be 10, and it keeps getting longer and longer as I recognize additional diagnoses, as I almost miss the diagnosis on additional cases. So one is SWE/SNF deficient carcinoma that we'll talk more about. These are undifferentiated carcinomas that are very variable in their broad spectrum epithelial marker positivity. They range from diffusely strongly broad spectrum epithelial marker positive to entirely negative. Sarcomatoid carcinoma, common especially in the head and neck, not uncommon in the lung, and can be seen at any site. Sarcomatoid carcinomas tend to be broad spectrum epithelial marker weak and occasionally negative. Poorly differentiated neuroendocrine carcinoma, small cell carcinoma. Occasionally, it's difficult to get keratin positivity on a small cell, and there are a bunch of additional markers to support a diagnosis of small cell that I'll talk about toward the end of the second hour. Adrenocortical carcinomas tend to be broad spectrum epithelial marker, weak to negative. SF1 is the best marker for adrenocortical carcinoma. Sarcomas, and I've highlighted, especially considered dedifferentiated liposarcoma in the mediastinum, retroperitoneum, and peritestis. GIST, dog1 and KIT, follicular dendritic cell sarcoma, which might be one of these S100 positive SOX10 negative tumors. And then this suite of LCA weak to negative lymphomas, acute lymphoblastic leukemia lymphoma, ALK positive large cell lymphomas, plasma cell neoplasm, and I showed you an example, classical Hodgkin lymphoma, plasmablastic lymphoma, dedifferentiated melanoma, which is a melanoma that loses expression of SOX10, S100, and then, of course, all the melanoma differentiation markers. The only way to make this diagnosis is to suspect it, and either in a patient with a personal history of melanoma, or in one of these quote unquote triple negative malignant neoplasms. And it's important to establish sort of exclude alternative diagnoses and establish some sort of genetics that would support the diagnosis of melanoma. And then the IHC surrogate for genetics in this space is BRAF V600E mutation-specific immunohistochemistry. Germ cell tumor and pheochromocytoma. These are the last few of the big four plus three more. Germ cell tumor, SAL4, parapheo, chromosynapto, but then also GATA3 positive, keratin negative. So this was a 39-year-old man with a giant tumor in the parotid. And this came my way after 50 or 60 immunos were performed, and my colleagues were stuck. And there's this giant tumor here, but actually for me, the clue to the diagnosis, this is an intraparotid lymph node metastasis. There was a second smaller lymph node with a tiny focus of tumor. And most of the tumor looked like this, which is large cell or epithelioid malignant neoplasm with, interestingly, with osteoclast-like giant cells. But in this small focus, this was SOX10, and that was the aha for me for the diagnosis. So here's the SOX10 in the large mass, it's negative. And I had mentioned that acinic cell carcinomas are SOX10 positive, and that serous acinar cells were SOX10 positive. So that's just an illustration of that. And in this case, I did a few immunostains, but this was the critical one. And this is BRAF V600E mutation specific immunohistochemistry. And based on this result, I raised the differential diagnosis of dedifferentiated melanoma. And the patient was referred to dermatology for a total skin exam. And he had this nodular lesion at the lateral canthus that he was Spanish speaking, and it was difficult for him to give history. It was difficult, like over the span in which this guy was engaged with our medical system. It was difficult to communicate. It was difficult to give and take. So he had never had the opportunity to tell anybody, hey, I've had this thing on my, next to my eye that popped up over the last few years. But when they went in to do a specific total skin exam, the dermatologist seized on this immediately. They excised it, and here's the lesion that's SOX10 positive. And this was, in fact, a dedifferentiated melanoma. So we're done with the tumor of uncertain lineage. We're flexing over to the carcinoma of unknown primary, and I hope that we'll use a lot of the tools that we've learned in the last hour to apply them to this sort of 35 to 40 minutes or so, and then we'll toss to questions. So clinical aspects of the carcinoma of unknown primary are dictated by the epidemiology of carcinoma of unknown primary, and common things are common. So what's common? Lung cancer in both genders, breast cancer in women, prostate cancer in men. So we're going to want imaging, either a chest radiograph, or often now we get CT of head and neck, chest, abdomen, and pelvis, pelvic exam and a mammogram for women, a prostate exam, and a serum PSA in a man. And empiric therapy is a platinum doublet. So that's platinum chemotherapy plus some other chemotherapy, some cytotoxic chemotherapy. There is no standard therapy. The survival is bad. Median survival is 7 to 10 months, and the 2-year survival is 20 to 25%. I'm going to highlight this brand new clinical guideline in CUP, which is really thoughtfully done. And if anybody is interested in this topic of carcinoma of unknown primary, it's really good in its focus on the clinical aspects, but also attention to immunohistochemistry. It's short and it's algorithmic and it's easy to read. One of the things that caught my eye in this reference is something that I knew intuitively, but a reference that provides the data to support the intuition. And the intuition is, if we make a specific tumor diagnosis, or in carcinoma, if we're able to suggest a specific primary, that the treatment can be tailored to the disease and the overall survival will be superior than if we just say CUP, carcinoma of unknown primary. And so in this paper, this was a large series of CUPs and then a population-based sample of other carcinoma types, with survival normalized to that for carcinoma of unknown primary. And hazard ratios in bold were statistically significant, and hazard ratios less than 1 means superior survival, and greater than 1 mean inferior survival. So if you can make a specific diagnosis of colon cancer or kidney cancer or prostate cancer or breast cancer, the survival is superior than saying, this is a carcinoma and I'm uncertain as to site of origin. I'm going to talk a little bit more about the epidemiology-based approach, which informs the construction of the algorithms and immunopanels that I'll share with you. And for my epidemiology-based approach, I analyzed publicly available US cancer data that was derived from the SEER, which is a surveillance, epidemiology, and end results, which is the US government's cancer epidemiology program, derived from SEER and packaged by the American Cancer Society, and then analyzed by me. And through this analysis, I found that in the States, 80% of malignant neoplasms are carcinomas, followed by hematolymphoid neoplasms, melanoma. And after that, everything else is quite rare. I said the big 3 are the big 4 plus 3 more, but really carcinoma, if you don't know what it is, it's likely carcinoma, or carcinoma, lymphoma, and melanoma. Keratin LCA S100, again, validating that broad screening, those big 3 screening markers. Among carcinomas, 80% of carcinomas are adenocarcinomas. And then among adenocarcinomas, here are the top 10 adenocarcinomas. with the point being that we have specific immunohistochemical markers for each of these sites of origin. And you can do this. Anybody can do this. I sort of behoove anyone anywhere in the world that's doing tumor diagnosis to take an epidemiology-based approach. And here's a tool that you can use to begin to do this. This is WHO sponsored international effort called the Global Cancer Observatory. And here's the website. I just Google Globocan when I need to go here. And you can visualize cancer epidemiology statistics for any country in the world. You can even hover over the map and click on a country. And I clicked on Nigeria and found actually that the cancer epidemiology, at least as reported and available through Globocan, is not entirely dissimilar from that in the States, with breast and prostate cancer dominating. But every country, every geographic region, and often, locally, you'll have unique aspects of your cancer epidemiology. So one thing that catches my eye right off the bat is a relatively high frequency of uterine cervical cancer, and suggests the relatively high incidence of high risk HPV. Some cancers are going to be very lower in a population. So in the States, melanoma is 6% of all incident cancers, but I see here that melanoma of the skin is really, really low on the list of cancers. Now, this epidemiologic data can be imperfect. There can be misclassification and underreporting, but it's a good place to start around informing your differential diagnoses and associated immunopanels. A point I'll make that if you get to carcinoma, there are only 7 choices. So it's either an adenocarcinoma, a squamous cell cancer, a urothelial cancer, a neuroendocrine tumor or cancer, and these are the common ones. And then these are rare. So sarcomatoid carcinoma with or without heterologous elements, an undifferentiated or dedifferentiated carcinoma, or very rarely a mixed carcinoma composed of 2 or more lineage. So an adenocarcinoma mixed with neuroendocrine carcinoma, for example. And maybe this is a wall hanger. We'll spend a lot of time on use of site-specific transcription factors to support the the site of origin of an adenocarcinoma. And we'll talk about screening markers for squamous cell carcinoma, markers to distinguish squame from urothelial. Here are markers to support a diagnosis of neuroendocrine tumor or carcinoma. And then at the end, we'll talk about this IHC and ISH toolbox for undifferentiated, dedifferentiated carcinoma. This is similar to the prior slide, but in sort of algorithmic form. Where to go once you get to a diagnosis of carcinoma, and I've suggested this a few times over the last hour that I recognize 4 main types or patterns of carcinoma, and that is garden variety adenocarcinoma, large polygonal cell adenocarcinoma, squamotransitional carcinoma, and neuroendocrine epithelial neoplasm. Garden variety adenocarcinomas are readily recognizable adenocarcinomas. They make glands and tubules and papillae and mucin. And I say, these are the adenocarcinomas that the inexperienced microscopist can easily recognize. And then we'll have an additional set of algorithms for them. Large polygonal adenocarcinomas tend to grow as cords or sheets, have centrally placed nucleoli, and clear or granular, sometimes granular eosinophilic cytoplasm. And the main large polygonal cell adenocarcinomas are HCC, hepatocellular carcinoma, renal cell carcinoma, and adrenal cortical carcinoma. And a common characteristic of large polygonal cell adenocarcinomas is CK7, CK20 simultaneous negativity. The squamotransitional carcinomas are squamous cell carcinoma and urothelial carcinoma. And I lump them together because they have overlapping immunophenotype and they're very difficult to distinguish morphologically, especially at a metastatic site. And then for neuroendocrine, we have tumors and carcinomas. So for large polygonal cell adenocarcinoma, HCC, I like HepAR and glypican-3 as positive markers, EpCAM negativity, that's MOC31 BERT EP4 negative. For RCC, the clear first choice is PAX8 for adrenal cortical carcinoma, SF1, steroidogenic factor 1. If you have it, if you don't, you have to resort to a panel including Melan A, Inhibin A, Calretinin, and synaptophysin. For squamotransitional, I screen with P40, 34 beta E12, which recognizes high molecular weight keratins, is more sensitive but less specific. So I've got it in the background, but I don't lead with it because up to 20% of adenocarcinomas are 34 beta E12 positive. GATA3 is useful to differentiate urothelial from squamous cancer. Urothelial cancers are usually GATA3 positive, and they're usually multifocal to diffuse, moderate to strong. Squames can be positive, but it tends to be weak and patchy. And then there are specific sites of origin that tend to be positive, namely squamous cell carcinomas of cutaneous or anogenitourinary origin. For neuroendocrine, we've got tumors and carcinomas. The tumors, we use chromogranin A and synaptophysin to support that diagnosis. And then I found in neuroendocrine carcinoma, poorly differentiated examples, that INSM1 is more sensitive than the combination of chromogranin and synaptophysin. I also look for RB loss to support a diagnosis of neuroendocrine carcinoma. And then we do Ki67. Most NETs, the vast majority of NETs have Ki67 proliferation indices less than 20%. And the vast majority of neuroendocrine carcinomas have Ki67 proliferation indices far in excess of 20%. Coordinate expression of CK7 and CK20. I find of all these different patterns, I find this first pattern to be the most useful, and that's CK7, CK20 double negativity, which causes me to, especially if I've locked in on a garden variety adenocarcinoma, to take a step back and reconsider the possibility of mainly these large polygonal cell adenocarcinomas, HCC, RCC, adrenal cortical, also squamous cell cancer, tends of visceral origin, tends to be CK7, CK20 double negative. Neuroendocrine tumors and carcinomas tend to be CK7, CK20 double negative. Yolk sac tumors, which may at first blush be mistaken for carcinoma, they're broad spectrum epithelial marker positive. They're fairly consistently CK7, CK20 double negative. And then also, I'll highlight prostate cancer is famously CK7, CK20 double negative. So this is an example of a case in which the site of origin was the carcinoma type and the site of origin were not initially recognized, in which CK7, CK20 double negativity should have been a clue to the tumor diagnosis. This was, and I thought I had a bit of history here, and I don't. This was a liver met in an older man. And if you go through the epidemiology-based approach, what's the tumor lineage? It's going to be carcinoma. 80% of all malignant neoplasms are carcinoma. And then among sites of origin, and then what's the tumor type going to be? Adenocarcinoma. What's the site of origin going to be? Prostate. So that's the most common diagnosis for a malignant neoplasm in an older man. And it was CK7, CK20 double negative. Keratin was positive, and this was signed out as poorly differentiated carcinoma of uncertain type and uncertain site of origin. But this morphology is fairly characteristic of a high-grade group prostate cancer. CK7, CK20 double negativity should, especially in this context, suggest the possibility of prostate cancer. And I did one immuno, and it was this NKX 3.1 to support a diagnosis of prostate cancer. And backing up several, the survival for a patient with prostate cancer, because you can androgen ablate with reasonable efficacy, is much better than the survival for CUP. And this gentleman was able to receive therapy specific to prostate cancer. Algorithm for quote unquote garden variety adenocarcinoma in the liver is based on the most common carcinomas to present, or I should say adenocarcinomas to present in the liver. And I do 720 CDX2 TTF, and in a woman I add GATA3. Here are the various patterns that might present based on initial immunopanel. So CK20 CDX2 homogeneous, that's diffuse strong staining. That's interpreted as tumor of lower GI origin, colorectum or appendix. CK20 CDX2 heterogeneous, that's any staining less than diffuse strong, raises the possibility of upper GI, esophagus, stomach, small intestine, or pancreatobiliary. TTF1 positivity favors lung, GATA3 positivity favors breast. And then the sort of problematic initial results, CK7 only and CK7, CK20 double negative. For CK7 only, I've got a list of immunos that you can consider adding in second panel: Napsin-A for lung, Pax8 for Mullerian, SOX10, and a new marker, TRPS1 for triple negative breast cancer. Cadherin 17 is a pan gastrointestinal marker. SMAD4, loss of which would support a diagnosis of prostate cancer. Albumin-ish, if you have it, to support a diagnosis of intrahepatic cholangiocarcinoma. I also use BAP1 to support a diagnosis of intrahepatic cholangiocarcinoma. And then if CK7, CK20 double negative, I said, oh, I find this to be useful to reconsider the possibility of hepatocellular carcinoma, renal cell carcinoma, adrenal cortical carcinoma, and prostate cancer. And I've already highlighted these markers for HCC, RCC, adrenal cortical, and prostate cancer, PSA, and in the example that I just showed you, NKX 3.1. So here's some examples of the staining pattern for CDX2. This is what I mean by homogeneous CDX2 positivity. It's diffuse and strong. Any staining less than this is I refer to as heterogeneous. This pattern, homogeneous CDX2, I refer to as lower GI pattern, and this heterogeneous CDX2 I refer to as upper GI pattern. This is a colon cancer. This is a gastric cancer. Here's CK20, and it works just the same. Homogeneous CK20 in a this was actually I think a low-grade appendiceal mucinous neoplasm that had spread to the peritoneum, and then heterogeneous CK20 upper GI pancreatobiliary pattern. And actually, this was a primary mucinous ovarian carcinoma, metastatic to the periureter. And this upper GI pattern, I mentioned esophagus, stomach, small intestine, pancreatobiliary tree. I should also mention that primary mucinous ovarian carcinomas also usually show upper GI pattern CDX2 and or CK20. Primary ovarian surface epithelial tumor versus metastasis. Next differential and sort of a site-specific differential. I use the gross. Is it unilateral or bilateral, and how large? So if bilateral, metastasis. If unilateral and large, likely primary. I also have an IHC algorithm that's very similar to the one in the liver, with a more circumscribed differential, really focused on a primary gynae tumor versus a spread from a GI origin. And here's that gross and immunohistochemical algorithm at work. So this is a large unilateral tumor, and this smacks of primary. And this is mucinous tumor smeared all over the TAH BSO specimen. And it seems like there's even a loop of small bowel that's been caught in this. And this is secondary involvement. And actually in this latter case, here's the appendix. And you can see a dilated mucin-filled appendix with mucoid material on the appendiceal serosal surface. Here's the immuno in the first case, the primary. So this was a CK7 only, 20 and CDX2 are negative. And here's the immuno in the second case. So we have homogeneous pattern, CDX2 and CK20. I'll make the point that the CK7 is positive. And in this algorithm, and the ovarian one, it's okay for CK7 to be positive. If CK20 or CDX2 homogeneous, then lower GI pattern. I'll make the point that 15% of colon and appendiceal tumors are CK7 positive, up to 25% of rectal cancers are CK7 positive. And in this instance, the homogeneous pattern CK20 and CDX2 positivity carry much more diagnostic weight. Additional site-specific differential diagnoses and immunopanels. So diagnostic considerations, if remember back to the very first slide of content, age, gender, anatomic location. So if they say that this is tumor in the mediastinum, here's the differential diagnosis. Lung, additional consideration, thymic neoplasm. Additional consideration, germ cell neoplasm. Additional consideration, well and dedifferentiated liposarcoma with associated immunohistochemical markers. Pleura, and I made this point, pleura and peritoneum, additional consideration of mesothelioma. In the peritoneum, especially, additional consideration of a Mullerian cancer in a woman. I have this retroperitoneal panel, so always consider renal cell carcinoma, adrenal cortical carcinoma, germ cell tumor, and liposarcoma, and all the way back sort of 10-15 minutes in after we did the broad screening, or the broad tumor classes and associated screening markers. I showed you an example of a seminoma that was almost missed, but my fellow said, oh, retroperitoneum, he didn't have to pull up this slide because it had been drilled into him, but it's right here, germ cell tumor cell 4. In somatic soft tissue, always consider sarcoma, even if keratin positive. And then in bone, 5 most common carcinomas to metastasize to bone: prostate cancer, breast cancer, kidney cancer, thyroid cancer, and lung cancer. And for prostate, PSA and or PSAP, NKX 3.1, great marker, but a transcription factor and occasionally challenged by the decal. So, it's not unreasonable to do either NKX 3.1, but have PSA in the background, or to lead with PSA, or to simultaneously lead with PSA and NKX 3.1, GATA3 for breast. I mentioned briefly SOX10 for triple negative breast, and more recently TRPS1 for triple negative breast. Kidney PAX8, RCC, best diagnostic marker PAX8. Thyroid tumors are going to be simultaneously positive for TTF and PAX8. Thyroid tumors, it would be exceptional for a thyroid tumor to present as a metastasis of occult origin. So knowing the clinical history, knowing about a personal history of malignancy is incredibly important. And then lung, TTF, or TTF and napsin A. We're getting there. We're an hour and a half in. My stamina needs another swig of diet Pepsi. I read off all the different things that we were going to do in the intro slide, in the outline slide, and I intimidated myself. I can't believe I'm going to try to do all this in an hour and a half, and we almost have. I've got about 10 more minutes, and then we can toss to questions. So squamous cell carcinoma versus urothelial carcinoma, and I'll make the point that it's in the bladder, it's pretty straightforward, or in the bladder and collecting system, it's pretty straightforward. It's usually urothelial carcinoma, unless there's schistosomiasis and squamous metaplasia. In the viscera, otherwise, in the lung, it's usually squamous cell carcinoma. But in the lung, in the liver, in the brain, in bone, at any potentially metastatic site, before you make a diagnosis of squamous cell carcinoma, you should always at least consider the possibility of urothelial carcinoma. And there are a handful of markers that are useful in the distinction. I'll highlight GATA3, which is usually positive in urothelial cancer and is usually moderate to strong and multifocal to diffuse. And GATA3 is positive in a minority of squames, mainly cutaneous and tumors of anogenitourinary origin, and would be exceptionally positive in a lung or tumor of lung or head and neck origin. Uroplakin 2 is really wonderfully specific in this differential and is reasonably sensitive. CK20, widely available and actually incredibly useful. Half of urothelial cancers are CK20 positive, and it's rare for a squame to be CK20 positive. So a lot of these markers, though, they're useful if they're positive. So GATA3 is useful if it's positive, and uroplakin is useful if it's positive, and CK20 is useful if it's positive. Here's another sneaky one. CK5/6 are high molecular weight keratins, and they're often used to screen for squamous cancer or squamotransitional cancer, but half of urothelial cancers are CK5/6 negative. So if you think something is a squamous cell cancer and your CK5/6 is negative, it's actually probably urothelial carcinoma. I've sort of already made this point. This is GATA3 expression in urothelial versus squamous cancer. Urothelial cancer is usually positive, usually rather strongly positive. Squames variably positive, and when positive, more weakly positive. This was a 61-year-old man with a history of muscle invasive bladder cancer. And now he has carcinomatosis, and this is a peritoneal biopsy. So age, gender, anatomic location, but then also never ignore a personal history of malignancy. This is a GATA3, and this is metastatic urothelial cancer. Point I'd like to make with this case is that P40, which I said I used to screen for squamotransitional cancers, is I have it here listed as greater than 95%, but it's probably even higher. It's probably greater than 98 or 99% sensitive for squamous cell carcinoma. It's still very sensitive, but manifestly less sensitive in urothelial cancer. The studies range, and the central mass is 85%. They range in sensitivity from 80 to 90%. So this is an example of a GATA3 positive, P40 negative urothelial carcinoma. Well, IHC for well-differentiated neuroendocrine tumor, which is a cottage industry at the University of Iowa hospitals and clinics. We have a huge multidisciplinary group, and I use this very complex algorithm to sort out site of origin. But this algorithm is probably more useful because it's based on markers that are more widely available. So neuroendocrine tumor, well-differentiated neuroendocrine tumor site of origin, CDX2, PR and or polyclonal PAX8, TTF1 and SATB2. CDX2 positivity supports midgut, jejunal-ileal origin. PR and or polyclonal PAX8 support pancreatic origin. TTF1 supports pulmonary origin, and SATB2 supports rectal origin. This is the very characteristic, stereotypical, idiosyncratic cytomorphology of a midgut, jejunal-ileal, EC cell, enterochromaffin cell, serotonin producing. These are all sort of overlapping terms. Neuroendocrine tumor. And the best marker for midgut neuroendocrine tumor is CDX2. It's about 90%, 90 to 95% sensitive, and the staining tends to be diffuse and strong. And that's the most common site of origin of neuroendocrine tumor, metastatic of occult origin. Second most common site of origin of metastasis of occult origin neuroendocrine tumor is pancreas. And I'd like to highlight that pancreatic neuroendocrine tumors demonstrate a very wide range of cytomorphologies. And the marker that I use, most sensitive marker, and marker that I use in combination with another, PAX6, but if I was going to use one, is islet-1. And here's islet-1 expression. But in the simplified algorithm, progesterone receptor and polyclonal PAX8. On to neuroendocrine carcinoma site of origin. I have all this elaborate transcription factor immunohistochemistry for NET site of origin. And the distinction that you can make with NEC, poorly differentiated neuroendocrine carcinoma, is much more limited. We can distinguish tumors of cutaneous versus visceral origin. And then among tumors of cutaneous origin, Merkel cell carcinoma, we can distinguish tumors driven by UV light versus Merkel cell polyomavirus. So here's a Merkel, here's a small cell lung cancer. And PDNex can be, this one's sort of epithelioid, this one shows more spindle cell morphology, but Merkel cell carcinomas can show this more spindle cell cytomorphology. The mini panel, the parsimonious panel, is CK20 and TTF. And CK20 is in excess of 90% sensitive for Merkel, and TTF is, and then it depends. Small cell lung cancer, TTF is positive in greater than 90%. Large cell neuroendocrine carcinoma, 40 to 50%. Extrapulmonary visceral, small and large cell neuroendocrine carcinoma, 40 or 50%. So we start with CK20 and TTF. And Merkel cells are exceptionally TTF positive, and when they are, it's rare cells weak. And small cell lung cancer is never CK20 positive. There are a couple sites of origin of extrapulmonary visceral necks that can be CK20 positive, mainly actually primary parotid and uterine cervical. Although it tends to, primary parotid can be extensive, uterine cervical is more variable. We need to be able to deal with CK20 TTF double negative tumors, and we have a couple additional immunos. This is CM2B4, which is immunohistochemistry for Merkel cell polyomavirus large T antigen, and this will identify the polyomavirus-driven Merkels. And we have neurofilament, which is positive in most Merkel cell carcinomas and is usually negative or weak and patchy in visceral neuroendocrine carcinomas, pulmonary and extrapulmonary visceral. So here's neurofilament positivity in a Merkel cell carcinoma. And then in addition to TTF, we also have ASCL1 positivity, for which would support a diagnosis of a visceral neuroendocrine carcinoma, never positive in a Merkel cell carcinoma. And then here's one more, and this is actually something that I had published, SAPB2, which we mainly use for colon cancer, and I briefly mentioned as a marker for B-core rearranged sarcomas, also a marker of osteoblastic differentiation. Diffuse strong SAPB2 expression is 70% sensitive and about 90% specific for the diagnosis of Merkel cell carcinoma. And it matters. It used to not. So distinguishing Merkel from visceral small cell used to have no, at least therapeutic import. The therapy was platinum etoposide, and either cisplatin or carboplatin, and the prognosis was terrible. But in the last several years, checkpoint inhibitor therapy, usually avelumab, and checkpoint inhibitor monotherapy has emerged as the gold standard therapy for Merkel cell carcinoma that's spread systemically with really, really high rates of response. So like overall response rates here of even 70%, and a complete response rate here at greater than 6 months of almost 30%. So site of origin assignment in poorly differentiated neuroendocrine carcinomas, because of the shifting therapeutic paradigms, become incredibly important. A couple more algorithms. This one's a little niche. I use this in my neuroendocrine practice, but there are lots of questions about this and this diagnosis, and that's morphologically ambiguous grade 3 neuroendocrine neoplasm. And here we're on the fence. Is this neuroendocrine tumor grade 3 or large cell neuroendocrine carcinoma? And for this, I take advantage mainly of the genetics of poorly differentiated neuroendocrine carcinoma. And poorly differentiated neuroendocrine carcinomas are characterized by biallelic inactivation of TP53 and RB1. And so we're looking mainly for abnormal P53 and RB immunohistochemistry. A couple other biomarkers that I use for this distinction: CXCR4, which is overexpressed by NEC, and SSTR2, which is highly expressed by NET especially, and is occasionally expressed by NEC. So if my differential is neuroendocrine tumor grade 3 versus NEC, and the P53 and RB are not mutant pattern, and especially if CXCR4 and is negative and SSTR2 is positive, I favor NET G3, and I go on with these NET site of origin specific algorithms, which for me is this, and for you might be this. If mutant pattern P53 or RB, or CXCR4 strong positive, SSTR2 typically weak to negative, interpretation NEC, and then we start with that TTF and CK20. Most frequent diagnostic errors in neuroendocrine neoplasia. So the most frequent one is mistaking a non-neuroendocrine carcinoma for a neuroendocrine carcinoma, usually in the setting of weak and patchy general neuroendocrine marker expression. To make a diagnosis of neuroendocrine tumors should always be diffusely strongly positive for chromogranin or synaptophysin. And for neuroendocrine carcinoma, we want our general neuroendocrine marker to be multifocal to diffuse and moderate to strong. Chromo, synapto, I said I prefer INSM1, actually. But in neuroendocrine carcinoma, that's often not the case. And so we have to resort to additional diagnostic markers, including, and I mentioned CXCR4, I mentioned RB loss. Another one would be dot-like keratin positivity. A few other diagnostic errors. So, I talked about this differential diagnosis of NET G3 versus NEC, and in my practice, most diagnoses of NET G3 that cross my desk in consultation are incorrect, and most are either NEC or this adenocarcinoma with occult neuroendocrine differentiation, which is, as I was just discussing, non-neuroendocrine carcinomas that show some general neuroendocrine marker expression, acinar cell carcinoma in the pancreas, and intrahepatic cholangiocarcinoma. And I'll show you an example of this in just a second. Failing to initially recognize a neuroendocrine tumor, and this is that, potential value of CK7, CK20 double negativity. A frequent error is equating CK7, a negative CK7 and CK20 with broad spectrum keratin negativity. And that CK7, CK20 double negativity is often seen in carcinomas, and it's seen in specific ones. So it's seen in prostate cancer, and I showed you an example of that. It's seen in HCC, RCC, adrenal cortical. It's seen in neuroendocrine tumor and neuroendocrine carcinoma. So if you have something that you think is an epithelial neoplasm and the CK7 and the CK20 is double negative, one consideration is neuroendocrine tumor or carcinoma. Mistaking a paraganglioma pheochromocytoma for NET, they're going to show overlapping cytomorphology, and they're going to be general neuroendocrine marker, chromogranin, synaptophysin, diffuse and strong. And so, especially at a potentially metastatic site, you should always support the diagnosis of NET with a broad spectrum keratin, or simultaneously perform an AE1, AE3, and GATA3 is the best marker for parapheo in the differential with NET. And then mistaking a small crushed neuroendocrine tumor on a forceps biopsy, usually rectal or endobronchial, for a neuroendocrine carcinoma. And this is one of many reasons why, in my opinion, Ki-67 immunohistochemistry should always be performed in a neuroendocrine neoplasm. So here's an example of something that was diagnosed as a NET G3 based on this was their synaptophysin that's poorly optimized. And I made the point that neuroendocrine tumors should always show diffuse strong staining for chromogranin and or synaptophysin. And this is really weak staining for synaptophysin, which I repeated in my lab and was entirely negative. This case is intrahepatic cholangiocarcinoma, and here's the BAP1. And BAP1 has several diagnostic applications in AP. One is to support a diagnosis of mesothelioma, but in an adenocarcinoma in the liver, especially, BAP1 loss supports a diagnosis of primary intrahepatic cholangiocarcinoma. All right, last section is how to deal with undifferentiated, dedifferentiated neoplasms in general, and then specifically undifferentiated, dedifferentiated carcinoma. So a little bit of terminology here. Undifferentiated malignant neoplasms show no evidence of light microscopic or immunohistochemical differentiation. So we can't figure out whether they're carcinoma, sarcoma, lymphoma, melanoma, germ cell tumor mesothelioma, or paraganglioma. Undifferentiated carcinomas, well, we're sure that they're carcinoma, but there's no evidence of glandular, squamous, or neuroendocrine differentiation. And we're sure that they're carcinoma based on keratin positivity or based on the anatomic site of presentation. They're presenting in the viscera or the skin, not in somatic soft tissue or the mediastinum or the retroperitoneum or the peritestis. Or they're arising in association with a precursor lesion, an adenoma. Undifferentiated sarcomas show no specific line of mesenchymal differentiation, but we're reasonably certain that they're sarcomas because carcinoma has been reasonably excluded with broad spectrum keratin negativity, and we're in somatic soft tissue or the mediastinum or the retroperitoneum or the peritestis again. And then dedifferentiated anything. And I showed you an example of dedifferentiated melanoma. Anything can dedifferentiate. Carcinoma, sarcoma, lymphoma, melanoma, germ cell tumor, mesothelioma, parapheo can dedifferentiate. And that's an undifferentiated cancer that's arising in association with the differentiated component, either by history or present. In the melanoma, it was present at a different anatomic site, or often concurrent, coexistent in the same specimen. And we're going to focus here on undifferentiated and dedifferentiated carcinomas. And if rhabdoid cytomorphology, we especially consider SWE/SNF deficient, undifferentiated, dedifferentiated carcinoma with immunohistochemistry for SMARCA4, synonym BRG1, or SMARCB1, synonym INI1. If prominent tumor-associated lymphoid stroma, then we consider the possibility of a microsatellite unstable tumor, and we do DNA mismatch repair immunohistochemistry and or MSI microsatellite testing. Epstein-Barr virus, we do ISH for EBER, and then rarely these tumors are driven by high-risk HPV, which we can detect by ISH or P16 immunohistochemistry. If a personal history of malignancy, again, over and over, if the patient has a personal history of malignancy, it's likely to be recurrence or metastasis of that malignancy, regardless of cytomorphology. And in some instances, the cytomorphology is really unusual because the tumor is transformed or dedifferentiated. And so I showed the example of using the BRAF V600E to link it up to melanoma. In some instances, I can compare molecular results between a prior tumor and a current unusual morphologic presentation of tumor. And if I can show unity in the molecular results, it supports a clonal relationship and that it's a dedifferentiated, whatever the primary was. And then in undifferentiated carcinoma with abrupt foci of abrupt keratinization, or especially in the mediastinum, head and neck, thorax, nut midline carcinoma is a consideration. We have immunohistochemistry for nut. So a couple examples of undifferentiated, dedifferentiated carcinoma. This is a large gastric mass that was referred to me by a former trainee, and he said, rule out large cell neuroendocrine carcinoma. But I'll point out in this one, first, it's epithelioid, it's monomorphous, and there's a bit of rhabdoid cytomorphology, and that is there are perinuclear, juxtanuclear, eosinophilic cytoplasmic whorls or inclusions. And here are some of the immuno. In this case, it was EMA positive. This was the only broad spectrum epithelial marker that was expressed in this case. And I said EMA only beware, but there was additional immunophenotypic evidence pointing away from one of those EMA positive lymphomas. Here's a SAL4. One point that I'll make that I haven't made strongly enough yet is I talk about added value of semi-quantitative IHC assessment, or I also say the stronger the staining for a given marker, the greater the diagnostic weight or diagnostic certainty. And so this amount of SAL4 positivity, which I said is a screening marker for germ cell tumor, it's not enough to support a diagnosis of germ cell tumor. It should be diffuse and strong. Here's synapto. Again, it's not enough to support his rule out differential, which was large cell neuroendocrine carcinoma, and this is CDX2 was negative. I did an INI1, and here's the SMARCA4, and this is a SMARCA4 BRG1 deficient undifferentiated carcinoma. Here's another example of the same. The difference in this case is there's simultaneously dysplastic Barrett's esophagus and an adenocarcinoma component. So this is, instead of undifferentiated carcinoma, is differentiated carcinoma because there's the simultaneous differentiated component. The SMARCA4 was deficient in both components. Point I'm making here is I had mentioned the keratins are very variably positive in SWE/SNF deficient carcinomas. So SWE/SNF subunits, they're chromatin remodelers. There's a bunch of them. They're frequently inactivated in cancer. And for a long time, we were familiar with INI1 or SMARCB1 that's inactivated mainly in a bunch of soft tissue tumors, like malignant rhabdoid tumor and epithelioid sarcoma. But about 5 years ago, it was discovered that this tumor type, small cell carcinoma of the ovary hypercalcemic type, note again the rhabdoid cytomorphology, was characterized by SMARCA4 BRG1 deficiency. And that sort of unlocked an examination of undifferentiated carcinomas at all anatomic sites. And we've subsequently discovered that, again, especially in these tumors with rhabdoid cytomorphology, that SMARCA4 deficiency is a common molecular genetic with an immunohistochemical underpinning of these undifferentiated malignant neoplasms. I'm going to mention, I've got, I think, one more case here. Not everything that's a dedifferentiated carcinoma is SWE/SNF deficient, and this is an endometrial tumor, endometrial biopsy, and we've got top chunk, bottom chunk, and the top chunk is a differentiated gland-forming endometrial cancer, endometrioid endometrial cancer. And at the bottom, we have an undifferentiated epithelioid malignant neoplasm. And this is the differentiated component at the top, the undifferentiated component, or I should say differentiated component at the bottom. Keratin is strongly positive, ER is strongly positive, P53 is wild type in both components. This is an MLH1 and PMS2 deficient tumor. Keratin rare cells in the dedifferentiated component, again emphasizing the variable keratin positivity in undiff and DDiff carcinoma. ER is negative. So this is a DDiff carcinoma that's due to MMR or dMMR deficiency, MSI high, and that's it. I failed to leave time for questions, though I'm glad to stay on the line for as long as anybody wants. But I actually made it through everything that I set out to do, and I'm delighted to have had this audience, and I'm a bit tired. Thank you, everybody. somebody say something. Maybe Dan stepped away from stepped away. All right, I'll just sit here in silence. I hope I haven't been on mute for the last 2 hours. Let's see. I see something in the Q&A. Great. Let's look at this. This is from Aliyu Lawan. Great. Looking at the fact that in some tertiary health institutions in Nigeria, IHC is not sustainable due to financial issues, where patients pay out of pocket, is there a list or panel you would suggest for developing countries? Presently, at best, we do breast panel, ER/PR, HER2, and limited lymphoma markers. Very few centers do more. This is a wonderful question. This is really the fundamental question. You know, I gave this 2-hour lecture and I mentioned probably 200 immunohistochemical markers. And IHC is amazing. And I'm the quote unquote IHC guy, but it's still in most cases an ancillary diagnostic, and H&E is the most important test. And this epidemiology based approach is really critical and essential. And so I welcome this. You know, feel free to reach out to me if you want to workshop around your local environment and what your common things are, and what resources you have at your disposal, and let's work to develop the best, most parsimonious panel. And so the ones that are mentioned here are great because ER/PR, HER2, and limited lymphoma markers, that's great because breast cancer is the most common cancer in a woman, and ER/PR, HER2 are going to help you direct your therapy. And lymphoma is not as common as carcinoma, but it's not uncommon. Let me pop up the data from the Globocan.
Andrew, while you're doing that, I just want to thank you. We're at time, so you can show this and then we'll conclude with the team. But one of the things I wanted to mention to the group, because you're discussing it right now, is that one of the approaches, and I'm sure Andrew mentioned this in his talk and has reiterated it several times, one of the approaches you should take to any of your diagnostics, but especially immunohistochemistry in light of the cost, is matching a test to a treatment, right? So if you start with the premise that if I perform this test, it will make a difference in what this patient's treatment is directly, that's something to put your energy into, right? Andrew's whole talk is about identifying the source of a tumor or the site of a tumor, because you need to know that to treat the patient, right? That's how the protocol goes for a tumor of unknown origin. But when you're looking at a breast cancer, ER/PR, HER2, those are directly related to treatment. And that's not true for all cancers. There's very few IHC, CD20, for example, for rituximab is another one that directly result in therapy. But if you streamline it that way, you do two things. You get the oncologist in your institution on your side, because they're like, oh yeah, we do need this. And hopefully you can find ways to pay for it. And you also streamline your costs and your program.
Thank you, Dan. Yeah, that's the critical point is to do what you can to have the greatest impact on patient care. And so having some limited lymphoma panel available is useful, because non-Hodgkin lymphoma here, it's 1, 2, 3, 4. It's number 5 on your incident cancer list. And I showed for the different cups that for different carcinoma sites of origin, prostate and breast specifically, like especially, that the prognosis is so much better than for cup. But for lymphoma, lymphomas can be terrible, but it's still better than carcinoma of unknown primary. I'd
True.
say if you're going to develop, I think this predictive parsimonious panel is great, but if you're going to distinguish between the first two talks, if I was going to build an IHC lab from scratch, I would have a well optimized broad spectrum keratin. I would have CD45 or CD45 and CD3. So I'm sorry, CD43 or CD45, CD43 and CD20, and S100 or SOX10 for melanoma, and then SAL4 for germ cell tumor, with germ cell tumor being another example like a lymphoma of a tumor that if you're able to successfully make that diagnosis of seminoma, for example, that tumor is going to shrink with PEB chemotherapy.
Yeah, absolutely.
Great.
Well, thank you, Andrew. This has been really wonderful. I appreciate it. And sorry we went over, guys. Remember, it is recorded, so you can watch it again at your leisure. And there was a lot of information in here. This is Andrew's email address, and please follow him on Twitter. And we thank all of you for your participation and for your questions.
Can't I see the number?
And Gloria, I think Gloria's got something to do. And we will see you all again on Tuesday.
Thanks, everybody.
Okay.
Thanks, Dan. Thanks for having me.
Andrew. All right. Bye-bye.
We'll see you around.